Okay. Hello, everyone. My name is Meg Hansell. Before I begin, I'd like to acknowledge that I live and work on the traditional unceded territory of the Comox First Nations. I completed my practicum in Island Health under the supervision of Tara Fitzgerald, who is the former director of the opioid response and the current director of public health. The majority of my practicum experience centered on the public health response to the opioid crisis, and I worked closely with the Population Health and Surveillance Department within Island Health. For my culminating project, I conducted an analysis of the service utilization trends and demographic distributions of individuals who access overdose prevention sites. So what made this project so relevant and so important to public health is the ongoing opioid crisis. Between 2016 and 2019, there were nearly 15,000 opioid-related deaths and over 19,000 hospitalizations related to opioids in Canada. As you can see, the province of British Columbia was particularly impacted by the crisis, and there were just over 5,000 deaths in the province from 2016 to 2019. In 2016, in response to the growing rate of opioid overdoses and opioid-related deaths, the province declared the opioid crisis a public health emergency. So the designation of a public health emergency does a couple things. It increases the surveillance powers of the province, and it supports the implementation of preventive interventions. Several interventions were introduced in response to the crisis. We saw an emergence of highly specialized substance use teams, take-home naloxone programs, and overdose prevention sites. So overdose prevention sites, or OPSs, as I'll refer to them, are a low barrier intervention that provides space for individuals to consume substances under the supervision of health professionals. This supervision allows an immediate response should an overdose occur. In addition to overdose prevention, OPSs provide a range of health services, including referrals to service providers, take-home naloxone, and harm reduction supplies. As a result, OPSs are associated with positive health and community outcomes, including decreases in risk behavior and mortality, and increased uptake of health services, just to name a few. Currently, there are 6 overdose prevention sites on Vancouver Island, located in communities across the island, including Victoria, Duncan, Nanaimo, Port Alberni, Courtenay, and Campbell River. Every OPS collects information on overdoses. Some of the OPSs additionally collect detailed service and demographic information. So that brings us to my culminating project. For this project, I consolidated and analyzed these detailed surveys from the OPSs in Duncan, Port Alberni, Courtenay, and Campbell River to reveal trends in service utilization and demographic distributions. From this analysis, I was able to identify service gaps and provide a series of recommendations to improve service efficacy. The methodology for the project was actually pretty simple because I used secondary data. At every OPS, staff collect detailed survey data, which is then sent to the Population Health and Surveillance Department at Island Health. I retrieved these logs and entered the data into an Excel spreadsheet. Finally, I analyzed the data to reveal the distributions of service trends and demographic characteristics. The analysis generated 4 main data trends. First, there were differences in service utilization between communities. Second, there were important differences in age distributions. Third, gender distributions were relatively consistent. And fourth, all communities demonstrated an underutilization of service potential. So let's break these down a bit and we'll talk about each one of them individually. As you can see from the graph, service utilization was much higher in Duncan and Port Alberni. These communities averaged 88 and 68 visits per day, compared to only 3 and 7 visits in Courtenay and Campbell River. Now, there's a number of variables that may explain these differences, but the one that stands out to me is that the communities that had the greatest service utilization, so Duncan and Port Alberni, are also the communities that have safe inhalation rooms. That means in addition to supervised injection, they provide space for supervised inhalation. This theory is supported by data from Port Alberni that shows that 77% of visits were for inhalation. So in addition to differences in service usage, there were also differences in age distributions. For example, the majority of visits in Duncan and Campbell River were from the middle-age demographic. Less than 40% were from the older, that means 40 plus, demographic. When we compare these distributions to the BC Coroner's report, we see that the older demographic accounts for the majority, 53%, of opioid-related deaths. This discrepancy indicates that the lack of service uptake by the older demographic may contribute to the higher death rate. Additionally, while visits from the youngest age group were generally under 1%, Duncan was a notable exception, where 3.1% of visits were by minors. Overall, these differences suggest the need to improve accessibility and develop targeted interventions for high-risk age groups. So in contrast to service usage and age distributions, gender distributions were relatively stable across communities. Men were more likely to access OPSs, and they accounted for up to 67% of the population. Conversely, women and transgendered individuals were less likely to access the sites, comprising up to 1% and 0 to 1% of the population accessing OPSs. These gender distributions are congruent with gender distributions for other substance-related indicators, and they generally provide support for the consistency of substance-related gender distributions. The final trend revealed from the analysis is the underutilization of health services. While all sites provided harm reduction supplies consistently, there were low levels of additional services being offered, including referrals and take-home naloxone. It's unclear why these additional health services are not being used, but it may be related to operational issues of time, space, or staff availability. Ultimately, this highlights an underutilization of service potential, and it represents an important opportunity for quality improvement. So based on the trends revealed by the analysis, I developed 4 overall recommendations. First, incorporate safe inhalation rooms into all OPSs to improve service utilization. Next, integrate alternative models of service delivery to ensure services are accessible for all age demographics. Then, design and implement interventions targeted to community-specific age and gender distributions to support early intervention and prevention initiatives. And finally, focus future research on barriers to service provision integration. The most recent BC Coroner's report suggests that opioid-related deaths have decreased by 36%. This signals a shift in the response to the opioid crisis from downstream emergency initiatives towards upstream preventative efforts. The analysis I completed for my Culminating project provides recommendations to support these initiatives and maximize OPS service delivery and efficacy. I'm going to finish this off with a quote published in the 1994 Kane report, referencing the heroin crisis in the downtown East Side. If you've worked with me, you know that this is my favorite quote, and I use it in every report I write. The drug problem is very real and very serious. It is a social problem as well as a health problem. The answers are not easily found, neither are the remedies cheap. The problems cover a wide range of issues, the solutions equally expansive and expensive, but unless these are dealt with head on and now, future generations may well be unable to contend with the consequences of our generation's unwillingness to face up to reality. Let this quote serve as a reminder of the intersecting factors that influence health and as a warning of what happens when the solutions fail to address the fundamental social inequities that cause disparities in health and ultimately lead to emergencies like the opioid crisis. So in closing, I'd like to thank Sarah Fitzgerald, my practicum supervisor extraordinaire, Elizabeth Colangelo, who supported my project from start to finish, Kurt Gould, my supervisor at my real job, who has been amazingly supportive and flexible with my work schedule over the last 2 years, and finally, the University of Victoria and all the people who make this program so fantastic. Thank you.
Well, thank you to you too. It was an excellent presentation. Fascinating. I'm sure there are going to be some questions. So I'm just looking to see if there are any questions coming up. I guess we're in a very sort of a unique situation where we have sort of two crises of major proportions. I'm not sure if that's ever happened before. There's a question from Kyla. Kyla, go ahead and ask your question.
Hi, Meg. Thank you so much for your presentation. That was really wonderful. I was just wondering if you could expand. I know that you said that 99% of harm reduction supplies were being utilized, but the other services weren't. I was just wondering, what are some examples of those other services?
So what it actually showed was which services the individuals who access overdose prevention sites are using. So basically, it showed that most people who go in there are accessing harm reduction supplies. The other one was referrals, and I think referrals were consistently under 1%. And then additional health services include, just access to social health providers and take-home naloxone as well.
Thank you so
much. No problem.
Chantel, you have a question.
Hi, great presentation. This isn't a question, but just a comment. So I think this topic is so important. I actually received naloxone training through my job, and I carry the kit with me. And I think it's so great that you did this presentation because it's so important. So thank you.
Thank you.
I believe, Jacqueline, have you put, I think you have a question, Jacqueline.
Yeah, thanks, Nigel. Hi, Meg. Thanks for your presentation. It's really quite powerful, and I'm really impressed with what you've been able to do with this data. I think it's really useful. You mentioned that, that some of these opioid prevention sites are being underused, and I remember from one of our conversations, you said that one of them, I think Campbell River, was being closed. Can you give some examples maybe of some alternative service delivery routes?
Sure. So it was the Courtney overdose prevention site that was recently closed. And I think in terms of alternative service delivery models, there's a ton of different options out there. I think the biggest barrier to service accessibility in the realm of substance use continues to be like the stigma associated with substance use, which I argue is a direct result of racially motivated prohibitive policies, but that's a different topic altogether. But I think, in terms of alternative service delivery, I mean, there's a bunch of different ones. My favorite one right now is episodic overdose prevention. So that is essentially integrating overdose prevention into all types of healthcare providers, whereby an individual who uses substances could walk into any island health facility, request supervised injection, and there would be someone there to support that. And then, of course, on like a broader level, decriminalization and safe supply.